The pressure inside the lungs' arteries is climbing until the right side of the heart simply gives out. Welcome back, future nurses. Today, we are tackling a massive, highly tested med-surg topic, pulmonary hypertension. Let's jump right into this high-yield, purely visual explainer to break down exactly what you need to know to pass. That is the literal life or death reality for a patient dealing with this disease. So let's map out exactly why this happens. Section 1, Pathophysiology, the core visual. Okay, look at how this all builds. Step 1, the pulmonary vessels narrow and stiffen up. Now this could be from vasoconstriction, remodeling, or maybe some clots. Step 2, because those pipes are so incredibly narrow, vascular resistance just skyrockets. So for step 3, the right ventricle of the heart now has to push incredibly hard just to get blood into the lungs. Think of it like trying to forcefully blow water through a tiny blocked straw. It's exhausting, right? And finally, step 4. Because it's working so hard, the right ventricle hypertrophies, meaning it enlarges, and eventually it just completely fails. We call that right heart failure, or Cor Pulmonale. This brilliantly illustrates the big picture here. Pulmonary hypertension is, at its core, a right-sided story. When that right ventricle gives out, the blood doesn't back up into the lungs, it backs up into the body. And actually, quick side note, the #1 cause of this, which is classified as WHO Group 2, is actually left heart disease, followed closely by lung diseases like COPD or chronic PE. Section 2, Signs and Symptoms, the clinical presentation. Now, the very first clue, the absolute earliest and most common sign you'll see is progressive dyspnea on exertion. Your patient is going to tell you, I just can't catch my breath when I walk up the stairs anymore. As it gets worse, you'll definitely see fatigue and weakness creeping in, but watch out for that huge red flag, exertional chest pain and syncope, basically fainting. If they are fainting on exertion, that means their right ventricle is acutely decompensating. The mortality there is super high. And finally, because of that systemic backup we just talked about, you're going to see classic right heart failure signs. We're talking jugular venous distension, peripheral edema, and a really swollen, enlarged liver, hepatomegaly. Section 3, Diagnostics, Screening versus Confirming. Notice the really clear distinction here, because this is a classic NCLEX trap. An echocardiogram is fantastic, right? It's non-invasive, it estimates the pressure, and it totally shows if the right ventricle is enlarged. But it is just a screening tool. The right heart catheterization is your gold standard. A catheter actually goes in and directly measures that elevated pulmonary artery pressure. So lock this in. An echo screens, but a right heart cath confirms. Section 4. Interventions and priority actions. Now, what's really interesting here is how we actually rank our actions as nurses. Let's build these step by step. #1 is oxygen. Why? Well, because hypoxia is a wildly potent pulmonary vasoconstrictor. A lack of oxygen actively makes those lung arteries clamp down even tighter, so giving oxygen directly lowers that pressure. Next up, we give pulmonary vasodilators to force open the vessels. Third, we got to support that failing right ventricle with diuretics to pull off all that backed up fluid. Fourth, we treat the underlying cause, whether that happens to be COPD or left heart failure. And fifth, we implement strict energy conservation and fall precautions. Remember, exertion can trigger fatal syncope, so we really don't want them overdoing it. Take a really close look at this critical warning. If your patient is on a continuous IV prostacyclin infusion, any sort of central line pump problem is an absolute drop-everything kind of emergency. The drug's half-life is literally mere minutes. You absolutely must always have a backup pump and line ready to go right at the bedside. No exceptions. Section 5. Medications and Safety Warnings. Pay super close attention to these red danger signs because these meds are highly tested. For prostacyclins, like epoprostenol, never, ever abruptly stop a continuous IV. Doing so causes a massive rebound pulmonary hypertensive crisis and, frankly, sudden death. Next, endothelin antagonists, absolutely avoid pregnancy. These are highly teratogenic, and maternal mortality with PH is already incredibly high anyway. And finally, PDE5 inhibitors, like sildenafil. Avoid combining these with nitrates at all costs, or you're going to cause a completely lethal drop in systemic blood pressure. Let's talk about emergency management. If that prostacyclin infusion we just talked about gets interrupted, your patient will suddenly have severe dyspnea, hypotension, and might literally pass out. Your immediate priority nursing actions: restore that drug infusion using your backup pump, crank up the high-flow oxygen to stop the hypoxic vasoconstriction, and call for urgent ICU help right away.
Section 6. Test yourself with some NCLEX prick.
Let's see how much you retained. Question 1. Untreated pulmonary hypertension most directly leads to which complication? Is it A, left ventricular hypertrophy, B, mitral valve prolapse, C, aortic stenosis, or D, right ventricular failure, also known as Cor Pulmonale? Drop your answer in the comments right now. 3, 2, 1. The answer is D. If you pictured our core visual from the beginning, you absolutely nailed this. Those chronically high pulmonary pressures act like a total brick wall, just overloading the right ventricle until it hypertrophies and eventually fails. Excellent job. Let's try one more. Question 2. A client with pulmonary hypertension is started on an oral pulmonary vasodilator. The nurse teaches that a key side effect to monitor is A, hypertension, B, systemic hypotension and dizziness, C, weight gain from fluid, or D, constipation. Get your answers in 3, 2, 1. And the correct answer is B. So the crucial point here is that while we are totally aiming to dilate the pulmonary vessels, these medications can kind of leak their effects into the rest of the body, lowering systemic vascular resistance too. This causes hypotension and dizziness, which means we, as nurses, are closely monitoring their blood pressure and keeping them on strict fall precautions. Section 7. Top pearls and memory tricks. Let's quickly lock in these top pearls. Remember, a right heart cath confirms the diagnosis, not the echo. The disease primarily causes right-sided heart failure, resulting in massive systemic backup. Dyspnea on exertion is your earliest, most subtle symptom. And safety first, you never, ever stop a continuous prostacyclin drip without a backup. When it comes to pulmonary hypertension, visualize the anatomy and you won't have to memorize a single thing. Master pH, it strains the right heart. But here's a thought. What other seemingly innocent patient complaints, like standard fatigue, are actually hiding a failing ventricle? Think about it. If this made it click, subscribe. One killer med search topic every day until you pass the NCLEX.